Usually when we talk about a medical diagnosis, there's this comforting expectation of just absolute precision.
Yeah, it feels almost like engineering, right?
Exactly. Like you break your arm, the x-ray shows that jagged white line fracturing the radius, and the doctor just points to the screen and says, well, there it is. That is the problem.
Right. It's either broken or not broken. It's a
Yeah.
very clean, visible binary.
Right. But the moment you step into the world of the human immune system, that comforting x-ray machine becomes completely useless.
Oh, totally useless. You're suddenly looking at a diagnostic landscape that is entirely microscopic. It's constantly shifting, and honestly, it's incredibly murky.
I mean, it's a biological battlefield where the friendly fire is sometimes vastly more dangerous than the actual invading pathogens.
Yeah, that's a great way to put it.
And for you listening right now, as you gear up for your major nursing exam, this is exactly the complex, high-stakes terrain we are mapping out today. Our mission for this deep dive is to tackle one of the most interconnected, highly tested systems in the entire human body, which is immunity and immune disorders.
And, looking at the stack of sources we're using today, the comprehensive ATI study guides, the pre-PU quiz rationales, all those dense pathology lecture notes, it's a massive cognitive load.
Oh, for sure. It's packed with intricate pathophysiology, shifting lab values, and there's incredibly dense pharmacology table.
Right. And the challenge is moving beyond just rote memorization, because passing a high-level clinical exam requires actually understanding the delicate, almost precarious balance the human body is constantly trying to maintain.
That concept of balance actually seems to be the overarching narrative hidden in all these study materials. I mean, the human body is essentially walking a tightrope.
Exactly. When the balance tips too far in one direction, the system underreacts.
Which is immunodeficiency, right? Where opportunistic infections, things that shouldn't really pose any threat to a healthy person, suddenly become lethal.
Yeah. But then, when the balance tips the other way, the system overreacts. That's your autoimmunity or your hypersensitivity reactions.
Where the body's own defense grid just turns its weapons inward and literally destroys healthy native tissue. So let's build this from the ground up, starting with how the immune system actually structures its defenses before things go wrong. The notes categorize this into 3 distinct lines of defense.
Right, and the structural organization here is brilliant in its redundancy. So the first line of defense is entirely non-specific and non-cellular. It's purely about creating an inhospitable environment for pathogens.
I always think of this first line like the architectural security of a highly exclusive nightclub or vault. It's the physical building, the thick walls, the velvet rope. In the body, this is your intact skin and your mucous membranes.
That's a perfect analogy. But it's not just a passive physical wall, is it? The notes emphasize the biochemical barriers here, too.
Yeah, the biochemical aspect is heavily tested because it represents active, continuous protection. Like the skin secretes sebum, right? Which contains fatty acids that lower the pH of the skin surface to an acidic level of around 3 to 5.
Exactly. And most pathogenic bacteria thrive in a neutral pH. So this acid mantle literally burns them away.
Wow, that's intense.
It is. And then you have lysozymes, which are these powerful enzymes present in tears, saliva, and sweat. They actively cleave the petidog-lichen cell walls of gram-positive bacteria.
Basically causing them to lyse or burst open before they ever breach the surface.
Right. And we can't forget the normal microbial flora. The gastrointestinal tract and the skin are colonized by trillions of commensal bacteria.
Oh yeah, the competitive inhibition concept. They basically take up all the real estate and consume all the local nutrients, so a foreign pathogen trying to set up camp just starves to death.
Exactly. But if a pathogen does manage to find a break, say, a deep laceration on the arm or a compromised mucosal lining, they hit the second line of defense.
Which is the innate immune response. The innate system is present at birth. It acts almost instantaneously, and crucially, it requires 0 prior exposure to a specific pathogen to initiate a full-scale attack.
Right. It relies heavily on a process called chemotaxis. Damaged cells release chemical distress signals like histamine and prostaglandins that draw phagocytic white blood cells right to the area.
The primary responders here are the phagocytes, right? Like the neutrophils and the macrophages. If the first line of defense was the physical vault, these are the massive indiscriminate bouncers inside.
Yeah, they don't care about a pathogen's specific identity or its past criminal record. If it doesn't have the biological equivalent of a VIP pass, they just engulf it and destroy it.
So, looking at the notes, neutrophils are the most abundant white blood cells, right? And they're the absolute first to arrive at a site of acute inflammation.
Yes, usually within 90 minutes.
Hmm.
And a critical clinical concept for the nursing exam here is understanding the shift to the left.
Oh, the shift to the left. I remember seeing that in the PPU rationales.
Yeah. When a patient has a severe acute bacterial infection, the bone marrow is signaled to churn out neutrophils so rapidly that it begins releasing immature neutrophils, called bands, into the bloodstream before they've fully developed.
So if a nurse looks at a CBC with differential and sees a high percentage of these bands, that is a massive red flag.
Huge red flag. It means the body's innate immune system is being pushed to its absolute limit, desperately throwing unformed recruits onto the battlefield.
Wow. And alongside the neutrophils, we have the macrophages. They start out as monocytes in the bloodstream, but when they migrate into the tissues, they swell up and become these highly phagocytic macrophages.
Right, they're the cleanup crew. They engulf dead tissue, dead neutrophils, bacteria, and they lock them inside a vacuole called a phagosome. Then that fuses with a lysosome filled with digestive enzymes to literally dissolve the invader.
That's amazing. Now, the notes also highlight a very unique cell in this second line of defense, the natural killer cell, or NK cell. And they operate a little differently than the phagocytes, don't they?
They do. They don't eat the enemy. They basically assassinate it from the outside.
Wait, how do they know who to assassinate if they're non-specific?
Well, NK cells are fascinating because of how they identify targets. Every healthy nucleated cell in the human body displays a surface protein called Major Histocompatibility Complex Class I, or MHCI.
Okay, so it's essentially a molecular ID badge that says, I belong here, I am self.
Exactly. Now, viruses and certain cancer cells often attempt to evade the immune system by downregulating or hiding this MHCI badge.
Oh, sneaky.
Very. But NK cells patrol the body, looking specifically for cells that are missing their ID. When they find one, they latch on and release perforins, which punch holes in the target cell's membrane.
And then they release granzymes, right? Which enter the cell and trigger apoptosis or programmed cell death.
That's ruthless biological efficiency right there. But even with the acid mantles, the swarming neutrophils, and the NK cell assassins, pathogens still survive.
Right, they mutate or they replicate too fast or they develop thick capsules that the neutrophils can't easily grab.
And when that happens, the body has to call in the third line of defense, which is acquired immunity. This is the elite, highly specialized tactical team. And the defining characteristic here is memory.
Okay, the acquired immune system learns. I mean, it takes longer to mount an initial response, often days to weeks, because it's busy analyzing the specific structural proteins or antigens of the invader.
Yes, but once it maps that antigen, it creates a permanent molecular memory. So if that exact same pathogen ever enters the body again years later, the response is so rapid and overwhelming that the host rarely experiences any symptoms.
So the study guides split this acquired immunity into two distinct tactical divisions, the humoral response and the cellular response. Let's unpack the humoral response first. This is commanded by the B cells, right?
Right. The notes indicate that the humoral response is entirely focused on producing antibodies, which are technically called immunoglobulins.
Okay, and B cells mature in the bone marrow. When a naive B cell encounters an antigen that perfectly matches its specific receptor, it undergoes clonal expansion.
Exactly. It rapidly divides into two types of cells: memory B cells, which go dormant to provide future protection, and plasma cells, which are essentially microscopic antibody factories.
And these plasma cells can pump out thousands of antibodies per second, which is mind-blowing. But these antibodies don't actually kill the pathogen directly, do they? I see a lot of students get tripped up on that concept.
Yeah, that's a common misconception. The antibodies are more like homing beacons or molecular handcuffs. They utilize several mechanisms, but direct destruction isn't one of them.
Right, they cause agglutination, clumping pathogens together so they're easier for macrophages to eat.
Yes. They neutralize viruses by binding to their surface receptors, preventing the virus from docking with a host cell. And they perform opsonization, coating the pathogen like a sugary glaze that makes it incredibly appetizing and easy to grip for the phagocytes.
Now, there is a major clinical trap hidden in the pathophysiology of these immunoglobulins, specifically regarding the different classes. The exam loves to test the difference between IgM, IgG, and IgE.
Oh, absolutely.
So if I'm looking at a patient's serology report, what does an elevated IgM tell me versus an elevated IgG?
Well, the distinction lies in the timeline of the infection. IgM is a massive molecule. It's a pentamer made of 5 basic antibody structures linked together. Because of its size, it stays primarily in the bloodstream.
Okay, so it's confined to the blood.
Right. It is the very first antibody produced in a primary immune response, usually appearing within 48 to 72 hours. Therefore, an elevated IgM titer definitively indicates an acute, active, and recent infection.
Got it. It's like the hasty, rough sketch of the wanted poster. The body is just churning out these massive, clunky IgM molecules to get some immediate control over the situation.
Exactly. And following that initial wave, the B cells undergo class switching and begin producing IgG. IgG is a smaller monomer, which allows it to easily slip out of the blood vessels and into the tissue spaces.
And IgG is the most abundant one, right?
It is. It represents the secondary immune response and long-term memory. If a patient's serology shows negative IgM but highly positive IgG for a specific virus, it means they were infected in the past, have recovered, and now have lasting immunity.
Oh, okay, that makes perfect sense. And because of its small size, IgG is the only immunoglobulin capable of crossing the placenta to protect a developing fetus. That feels like a very testable fact.
It is a very high-yield fact.
Okay, so IgM is acute, IgG is chronic or memory. What about IgE? Because that one seems to operate in a completely different clinical lane in these notes.
Yeah, IgE is highly specialized. It is the immunoglobulin responsible for mediating allergic reactions and mounting defenses against parasitic worm infections.
Oh, right. IgE molecules bind tightly to the surface of mast cells and basophils.
Yes, and when an allergen like, say, pollen or peanut protein cross-links with those bound IgE molecules, it causes the mast cell to violently degranulate, dumping massive amounts of histamine and inflammatory cytokines into the surrounding tissue.
So a patient presenting with watery eyes, pale nasal mucosa, and bronchospasm from seasonal allergies is going to have significantly elevated IgE levels.
Exactly. Which perfectly transitions us to the other half of the acquired immune system, the cellular response.
Right, so if the B cells handle the antibodies circulating in the fluids, the humors, the T cells handle the hand-to-hand combat at the cellular level.
Yes, and the notes focus heavily on two specific types of T cells: helper T cells, which carry the CD4 receptor, and cytotoxic T cells, which carry the CD8 receptor.
Let's talk about those helper T cells, the CD4s. The notes say they're arguably the most important cells in the entire immune cascade.
They really are. They're off the master regulators, the generals of the immune army.
Yeah.
They cannot kill pathogens, and they cannot make antibodies. Instead, they act as the central communication hub.
How does that communication work exactly?
Well, when a macrophage eats a pathogen, it travels to a lymph node and presents a piece of that digested pathogen to the CD4 cell. The CD4 cell analyzes it and then releases powerful chemical messengers called interleukins and cytokines.
And those chemical messengers are what actually trigger the B cells to start making those plasma factories and what trigger the macrophages to become even more aggressive.
Right. If you lose the CD4 generals, the entire communication network collapses. The B cells wouldn't know what antibodies to make, and the frontline troops wouldn't know where to go.
That's terrifying. And the other side of the T cell coin is the cytotoxic T cell, the CD8. These are the specialized assassins.
Yes. While NK cells from the innate system look for cells missing an ID badge, CD8 cells read the specific antigen presented on the MHCI badge of infected cells.
So if a host cell has been hijacked by a virus, it will display viral proteins on its surface, and the CD8 cell recognizes that specific viral protein, binds to the infected cell, and injects toxic enzymes to trigger apoptosis.
Destroying the cell to prevent the virus from replicating further, exactly.
Yeah. I noticed a really interesting application of this cellular response in the prep questions regarding organ transplants. Like, a student might think, well, T cells are incredibly smart. They only attack things that are harmful, like viruses or cancer. But if a patient receives a life-saving kidney transplant, their T cells will relentlessly attack it if they aren't suppressed. Why does the body reject an organ that is literally keeping it alive?
It's because the cellular response operates on strict biological logic, completely devoid of context. It comes back to those MHCID badges, which are also known as human leukocyte antigens, or HLA.
Okay, and every person's HLA typing is genetically unique, almost like a cellular fingerprint.
Yes. So when a surgeon implants a donor kidney, the cells of that kidney display a foreign HLA fingerprint. The host's CD8 cytotoxic T cells don't perceive a helpful functioning organ. They perceive billions of foreign cells invading the body.
Oh, wow. So the CD4 generals sound the alarm, the CD8 assassins infiltrate the new tissue, and they begin systematically destroying the transplanted kidney.
Exactly. Transplant rejection is almost entirely mediated by the cellular T cell response.
This concept of the immune system causing extreme damage through its normal mechanisms sets up a crucial topic for the exam hypersensitivity reactions. The sources categorize these into 4 distinct types: numbered I through 5.
And the challenge here isn't just memorizing the list, it's understanding the exact pathophysiology of how the body is hurting itself in each scenario. Understanding the mechanism and the timing is the key to differentiating them clinically.
Let's start with type I immediate hypersensitivity. This is the classic allergic response, and it happens in seconds to minutes. This is the IgE-mediated response we discussed a moment ago.
Exactly. Let's map it out. A patient with a severe peanut allergy ingests a peanut. They've already been sensitized in the past, meaning their mast cells are coated with millions of peanut-specific IgE antibodies.
So the peanut proteins enter the bloodstream, bind to those IgE receptors, and trigger instantaneous systemic mast cell degranulation.
Yes, and the release of histamine is catastrophic. The histamine binds to H1 receptors in the smooth muscle of the bronchioles, causing severe bronchospasm and wheezing.
And it binds to endothelial cells in the blood vessels, causing massive vasodilation and increasing capillary permeability. The blood pressure plummets, fluid leaks into the tissue, causing laryngeal edema, and the patient goes into anaphylactic shock.
Which is rapid and requires immediate administration of epinephrine to cause vasoconstriction and bronchodilation. That's type 1.
Okay, moving to type 2, cytotoxic hypersensitivity.
In this mechanism, the patient's own antibodies, usually IgG or IgM, mistakenly identify specific antigens on the surface of target cells as foreign. They bind to them and activate the complement cascade to destroy those specific cells.
The classic clinical vignette for type 2 on the nursing exam is a hemolytic blood transfusion reaction, isn't it?
Yes, that's the absolute textbook example.
So imagine a patient with type O blood, meaning their plasma naturally contains anti-A and anti-B antibodies. If a nurse accidentally hangs a bag of type A blood, those anti-A antibodies will immediately recognize the A antigens on the donor red blood cells.
They bind to the cells, activate complement, and cause massive intravascular hemolysis. The red blood cells burst open, spilling hemoglobin into the bloodstream,
which can quickly clog the renal tubules and cause acute kidney failure. So the damage is highly localized to the specific cells displaying the targeted antigen. That's type 2.
Right. Now, type 3 is called immune complex-mediated hypersensitivity, and the pathophysiology here is profoundly different and incredibly important for understanding autoimmune diseases.
How so?
In type 3, antibodies, again, mostly IgG, bind to free-floating antigens in the bloodstream rather than the antigens fixed to a cell surface.
Okay, so when they bind together, they form these tangled molecular clumps called immune complexes. I try to visualize these complexes as like microscopic garbage floating through the bloodstream.
That is an excellent way to visualize it. Normally, macrophages in the spleen and liver clear this microscopic garbage. But in a type 3 reaction, there are far too many complexes, or they're the wrong size to be easily cleared.
So they just continue to circulate?
Yes, until they eventually precipitate out of the blood and get stuck deposited in the delicate microvasculature of various tissues. They love to get trapped in the synovial membranes of joints, the basement membranes of the kidneys, and the walls of small blood vessels.
And once this garbage gets wedged into the tissue, the immune system detects it and tries to clean it up. It sends in the neutrophils. But the neutrophils can't easily engulf these stuck complexes, so they experience what the techs call frustrated phagocytosis.
Frustrated phagocytosis, exactly. They just start violently dumping their digestive enzymes and reactive oxygen species directly into the surrounding tissue, causing massive systemic destruction of healthy joints and organs.
And this is the exact mechanism driving devastating diseases like systemic lupus erythematosus and rheumatoid arthritis, which we're going to deep dive into later.
Yes, type 3 is the driver for those. Finally, we have type 4, delayed type hypersensitivity. The defining characteristic here is that it is not mediated by antibodies at all.
Really? No antibodies?
None. It is entirely mediated by T cells, which is why it takes 48 to 72 hours for the clinical reaction to peak. It takes time for the T cells to migrate to the site of antigen exposure, release cytokines, and recruit macrophages to cause inflammation.
Right. The textbook example for type 4 is contact dermatitis from poison ivy, or the localized induration of a positive PPD skin test for tuberculosis.
Exactly. When the purified protein derivative of TB is injected under the skin, a patient who has been previously exposed to TB will have memory T cells that slowly migrate to the injection site over 2 to 3 days, eventually creating a hard, raised red bump.
Okay, so knowing precisely how the body builds memory and how it can dangerously overreact explains exactly why we intervene pharmacologically. We either want to safely trigger that memory formation without risking the actual disease, or we need to forcibly suppress the communication network to stop a type 2, 3, or 5 hypersensitivity from destroying the body.
Which brings us directly to the concepts of immunizations and immunosuppressant pharmacology in Section 2.
This is an incredibly high-yield area. Let's clarify the terminology first, because the exam will test the difference between active versus passive immunity and natural versus artificial immunity. It seems to be all about who is doing the physiological work and how long the protection lasts.
Exactly. Active immunity means the patient's own immune system does the heavy lifting. The body is exposed to an antigen, the B cells undergo clonal expansion, and they produce their own antibodies and memory cells.
And because memory cells are created, active immunity provides long-lasting, sometimes lifelong, protection.
Right. Now, active natural immunity is the historical way we survive. You contract wild-type chickenpox as a child, you suffer through the fever and the itchy vesicles, your body fights off the live virus, and you develop permanent memory cells.
Whereas active artificial immunity is the miracle of modern medicine, the vaccine. We artificially introduce a killed or attenuated version of the pathogen. The body still does the active work of creating antibodies and memory cells, but without the danger of a full-blown clinical infection.
Perfect. Passive immunity is the exact opposite. It means the patient's body gets a free ride. The antibodies are handed over fully formed, meaning the host B cells never engage with the antigen.
And crucially, zero memory cells are created.
Exactly. Passive immunity provides immediate, instantaneous protection, but because those foreign antibodies eventually degrade, the protection is strictly temporary, lasting only weeks to a few months.
So, passive natural immunity is the transfer of maternal IgG antibodies across the placenta to the fetus, or the transfer of IgA antibodies through breast milk to a nursing infant. It bridges the gap until the infant's own immune system matures.
And passive artificial immunity is the clinical administration of preformed immunoglobulins, usually derived from the pooled plasma of human donors. We utilize this when a patient has suffered a high-risk exposure, and we simply do not have the weeks required for a vaccine to trigger an active response.
Like, if a patient is bitten by a rabid bat or sustains a deep needle stick injury from a hepatitis B positive patient, you administer rabies immune globulin or hepatitis B immune globulin. You are directly injecting neutralizing antibodies to bind the virus immediately before it can replicate.
That's it, exactly.
Let's focus on the active artificial side, the vaccines. The source notes are loaded with specific contraindications and allergy traps that nursing students must recognize. We need to look at the mechanism behind the vaccine to understand the precaution. Let's start with the MMR, measles, mumps, rubella, and the varicella, or chickenpox, vaccines.
The foundational concept here is that MMR and varicella are live, attenuated vaccines. The viruses inside the vial are live, but their virulence has been artificially weakened in a lab.
They replicate inside the body just enough to trigger a robust immune response, but not enough to cause disease in a healthy person.
Exactly. However, because they contain replicating viruses, they are strictly contraindicated in two specific populations: pregnant women, due to the risk of the virus crossing the placenta and infecting the fetus, and severely immunocompromised patients, such as those with untreated AIDS, leukemia, or patients actively undergoing chemotherapy.
I mean, for an immunocompromised patient, taking a live vaccine is like handing a lit match to someone soaked in gasoline. Their immune system cannot contain even the weakened virus, and it will rapidly replicate into a full-blown, potentially fatal infection.
Absolutely.
There's also a highly specific clinical detail in the notes regarding the varicella vaccine. It says, if a child develops a vesicular rash near the injection site a week after receiving the vaccine, a nurse must assume they are infectious and take contact precautions.
Yes. Because it's a live virus, that rash can actually spread vaccine-strain chickenpox to susceptible individuals. We also need to assess for specific hypersensitivities before administration, which brings us back to those type allergic reactions.
Right, because viruses cannot replicate on their own. They require host cells. In the manufacturing process, many viruses are grown in specific cell cultures.
And the influenza vaccine and the MMR vaccine are often cultivated using chick embryos. Therefore, a severe anaphylactic allergy to eggs or gelatin is a major precaution.
Now, I noticed a really specific allergy warning for the hepatitis B vaccine and the notes Baker's yeast. That seems so random compared to egg allergies. How are they manufacturing Hep B that involves yeast?
Oh, it's a brilliant piece of biotechnology. The hepatitis B vaccine is not a live virus, nor is it a killed whole virus. It is a recombinant viral protein.
Wait, really? How does that work?
Scientists took the genetic code for the hepatitis B surface antigen and spliced it into the DNA of common Baker's yeast cells. They grow massive vats of this genetically modified yeast, which churns out the viral protein.
Wow, so the protein is then purified and bottled as the vaccine.
Exactly. But because of this process, trace amounts of yeast protein remain, making a severe yeast allergy a strict contraindication.
That perfectly explains the why behind that flashcard fact. Let's look at one more vaccine warning the DTaP diphtheria, tetanus, and acellular pertussis.
The pertussis component of the DTaP vaccine carries a rare but serious risk of neurological side effects, likely due to the highly immunogenic nature of the pertussis toxin proteins.
So if a child has a history of developing encephalopathy within 7 days of a previous DTaP dose, or if they experienced a seizure or inconsolable crying lasting more than 3 hours within 48 hours of the shot, further doses of the pertussis component are contraindicated.
Right, they would simply receive the DT vaccine instead.
All right, so that explores how we purposefully stimulate the immune system. But what about the clinical scenarios where the immune system is the enemy? When a patient is suffering from a type 3 autoimmune disease like severe rheumatoid arthritis, or when they've just received a kidney transplant and their CD8 T cells are actively trying to destroy it, we have to forcibly shut the communication network down.
Which brings us to immunosuppressants, and we absolutely have to start with the cornerstone of medical surgical pharmacology, prednisone.
Prednisone, it's a synthetic glucocorticoid, right? It is an exceptionally powerful anti-inflammatory and immunosuppressant.
It works by entering the cell nucleus and literally altering gene transcription. Specifically, it inhibits the production of phospholipase A2, which is an enzyme at the very top of the arachidonic acid cascade.
So by blocking this, prednisone stops the production of nearly all inflammatory mediators, prostaglandins, leukotrienes, and histamine. It also suppresses the migration of polymorphonuclear leukocytes and decreases capillary permeability.
The mechanism is highly effective, but the collateral damage across the body's systems is massive. The notes list profound side effects.
Yeah, for instance, prolonged use of prednisone causes severe osteoporosis. It's not just a vague side effect, it physically alters bone remodeling.
Exactly. Glucocorticoids directly inhibit the function of osteoblasts, the cells that build bone, while simultaneously decreasing the intestinal absorption of calcium.
So the body senses the low blood calcium and signals the parathyroid glands to release parathyroid hormone, which activates osteoclasts to break down bone to release more calcium. It's like a double hit to bone density. Patients must be heavily supplemented with calcium and vitamin D.
And the metabolic effects are equally severe. Prednisone causes significant fluid and sodium retention, leading to hypertension and edema. It drastically alters glucose metabolism, causing gluconeogenesis in the liver and creating insulin resistance in the peripheral tissues.
Wow, so even patients with absolutely no history of diabetes can develop severe hyperglycemia and require regular blood glucose monitoring and insulin administration while on steroid therapy.
Yes, and we cannot stress this next point enough, because it is the absolute golden rule of NCLEX pharmacology regarding systemic steroids. You must never, ever stop them abruptly. They require a strict, gradual tapering process.
The pathophysiology of this rule lies in the hypothalamic pituitary adrenal, or HPA, axis. Normally, your adrenal glands constantly secrete cortisol to manage stress and basic metabolic functions.
But when you administer a massive dose of artificial prednisone, the brain senses the high steroid levels and signals the adrenal glands to shut down production.
So if you suddenly stop the prednisone, the dormant adrenal glands cannot wake up fast enough to resume producing natural cortisol.
And the patient immediately crashes into an acute adrenal crisis, profound hypotension, hypoglycemia, and cardiovascular collapse. Tapering the medication over weeks or months slowly wakes the adrenal glands back up.
Okay, let's shift to a more targeted immunosuppressant, cyclosporine. This is a critical medication for preventing organ transplant rejection.
Right. Unlike prednisone, which blasts the entire inflammatory cascade, cyclosporine is highly specific. It is a calcineurin inhibitor. It specifically blocks the production of interleukin-2 inside CD4 helper T cells.
And if you recall our cellular response discussion, interleukin-2 is the exact chemical messenger the CD4 general uses to trigger the massive proliferation of CD8 assassins.
Exactly. By blocking IL-2, cyclosporine effectively silences the generals, preventing the entire T cell army from mobilizing against the transplanted organ.
But it comes with immense toxicities. Cyclosporine is highly nephrotoxic. It severely constricts the afferent arterioles in the kidneys, reducing blood flow and damaging the delicate glomeruli. primarily.
So nurses must meticulously monitor strict intake and output, alongside daily BUN and creatinine levels. And there's a massive pharmacological interaction trap that appears on almost every exam the patient must absolutely avoid grapefruit juice.
Yeah, the mechanism behind this interaction is fascinating. Cyclosporine is heavily metabolized by a specific enzyme in the liver and the intestinal wall called cytochrome P450-3A4, or CYP3A4.
And grapefruit juice contains compounds called furanocoumarins, which completely inhibit the action of the CYP3A4 enzyme.
So if the enzyme is blocked, the cyclosporine is not broken down, and its concentration in the bloodstream rapidly skyrockets by upwards of 50%, leading straight to acute renal failure and profound immunosuppression.
It's a huge NCLEX trap. The last major immunosuppressant highlighted in the study guides is methotrexate, which is heavily used for severe refractory rheumatoid arthritis.
Methotrexate is technically an antimetabolite, a type of chemotherapy drug, right?
It is. It acts as a structural analog to folic acid. It tightly binds to and inhibits an enzyme called dihydrofolate reductase, which cells desperately need to convert dietary folate into its active form to synthesize DNA.
Because immune cells, like rapidly dividing lymphocytes attacking a joint, require massive amounts of DNA synthesis to replicate, methotrexate starves them of the necessary building blocks, halting the autoimmune attack.
But the body has other rapidly dividing cells that rely on that same folate pathway, leading to severe side effects. It causes dose-limiting bone marrow suppression, resulting in neutropenia, which increases the risk of life-threatening infections.
And thrombocytopenia, which dramatically increases the risk of spontaneous hemorrhage. The rapid turnover of mucosal cells in the gastrointestinal tract is also halted, leading to severe stomatitis, painful ulcerated lesions throughout the mouth and throat.
Yes, so patients are explicitly educated to avoid any alcohol-based mouthwashes.
Yeah.
Furthermore, because it blocks DNA synthesis, it is a potent teratogen and is strictly contraindicated in pregnancy as it will cause devastating fetal malformations or miscarriage.
It's just wild. We expend immense medical effort using these dangerous drugs to carefully take the CD4 generals offline to save organs and joints. But what happens when something malicious does that for us?
Because that is exactly what HIV is doing. It's not just a virus causing an infection, it's a targeted biological assassination of the exact CD4 communication network we just mapped out.
The transition from discussing immunosuppressive drugs to discussing the human immunodeficiency virus in Section 3 is just staggering when you look at the pathophysiology. The virus essentially induces the exact same vulnerability as high-dose methotrexate or cyclosporine, but it does it relentlessly and permanently.
Let's examine the nature of this pathogen. HIV is classified as a retrovirus, which fundamentally changes how it interacts with human cells.
Right, because most biological life forms store their genetic blueprint as double-stranded DNA, which is then transcribed into single-stranded RNA, which is then translated into the proteins that build the organism. It flows from DNA to RNA to protein.
But a retrovirus completely subverts this central dogma. HIV carries its genetic blueprint exclusively as single-stranded RNA. When it infiltrates a host cell, it brings along a unique, highly error-prone enzyme called reverse transcriptase,
which forces the host cell to read the viral RNA and synthesize a complementary strand of viral DNA. It literally writes its code backward into the host's operating system.
Exactly. And the study guides painstakingly outline the exact 7-step life cycle of HIV. For a nursing student, memorizing these microscopic cellular steps might seem like overkill, but it is actually the absolute key to understanding modern HIV pharmacology.
Because every single class of drug in highly active antiretroviral therapy, or HAART, is designed to throw a roadblock in front of one specific step of this life cycle. Let's break down this 7-step hijacking process and map the drugs directly to the pathophysiology. Step 1 is binding or attachment.
Right. HIV cannot simply float into any cell. It requires a highly specific lock and key mechanism. The surface of the HIV envelope contains a glycoprotein called GP120. This GP120 perfectly matches the CD4 receptor found on the surface of helper T cells.
But the CD4 receptor alone isn't enough, right? The virus must also bind to a co-receptor, most commonly one called CCR5, to stabilize the attachment.
Yes, and we target this initial docking phase with a class of drugs called CCR5 antagonists, which bind to the host's CCR5 receptor, blocking the virus from anchoring.
Okay, so once anchored, we move to step 2, fusion. The viral envelope essentially melts into the host cell's membrane, creating an opening that allows the viral RNA and enzymes to drop into the host cell's cytoplasm.
And we block this physical merging with fusion inhibitors.
Got it. Step 3 is the defining moment, reverse transcription. Once inside, the viral enzyme reverse transcriptase begins converting the viral RNA into double-stranded viral DNA.
This enzyme is incredibly sloppy and makes frequent transcription errors, which is why HIV mutates so rapidly. We hit this step incredibly hard with two major classes of drugs.
Nucleoside reverse transcriptase inhibitors, or NRTIs, which provide faulty DNA building blocks that jam the enzyme's machinery, right?
Yes. And non-nucleoside reverse transcriptase inhibitors, NRTIs, which physically bind to the enzyme itself and lock it down.
Amazing. Now, if the virus successfully creates that viral DNA, it moves to step 4 integration. The new viral DNA slips into the nucleus of the CD4 cell, and an enzyme called integrase literally snips open the host's own human DNA and splices the viral DNA directly into the chromosome.
The host cell is now permanently infected. Its own genetic code has been rewritten. We deploy integrase inhibitors to block this splicing action.
Which brings us to step 5 replication. The hijacked CD4 cell, following the newly integrated viral instructions, unknowingly begins utilizing its own cellular machinery to transcribe long chains of viral RNA and translate massive viral polyproteins.
Right. Then step 6 is assembly, where these newly manufactured viral RNA strands and protein chains migrate to the inner surface of the host cell membrane and begin clumping together, forming an immature, non-infectious viral particle.
And finally, step 7, budding. The immature virus pushes its way out of the host cell, stealing a piece of the cell's membrane to act as its own new viral envelope.
But even after it buds off, it's not fully operational. It relies on a viral enzyme called protease to act like microscopic scissors, chopping up those long, clunky polyprotein chains into the final functional structural proteins that make the virus mature and highly infectious.
And that gives us our final major drug class protease inhibitors, which leave the virus in an immature, harmless state.
Exactly. By combining 3 or more of these drugs from different classes, the strategy behind HART, you attack the virus at multiple stages of its life cycle simultaneously.
So even if the rapidly mutating virus develops resistance to an NRTI, the protease inhibitor and the integrase inhibitor are still blocking replication. This multi-pronged attack drives the viral load down to undetectable levels in the blood, halting the destruction of the CD4 cells.
And effectively transforming HIV from a fatal diagnosis into a manageable chronic illness.
Now, regarding transmission, the clinical realities are stark. The exam tests a nurse's ability to educate patients and separate physiological fact from enduring societal fiction. How is HIV actually transmitted?
The virus must be transmitted through specific body fluids that carry a high viral load, and those fluids must have a direct route into the recipient's bloodstream or across highly permeable mucous membranes.
The primary vectors are blood, semen, vaginal secretions, and breast milk. Transmission occurs through unprotected sexual contact, sharing contaminated intravenous needles, accidental occupational needle sticks, or vertical transmission from an infected mother to her infant during childbirth or breastfeeding.
Right, but the NCLEX prep questions frequently push back on what does not transmit the virus. A student might assume that any bodily fluid is a vector, but the viral load in certain fluids is too infinitesimally small to cause infection.
Casual contact, hugging, or sharing utensils does not transmit HIV. Saliva, tears, and sweat do not contain sufficient viral concentrations. And a classic recurring exam trap, urine and feces, do not transmit HIV unless they are visibly contaminated with blood.
When an exposure does occur, the testing timeline becomes the most critical factor. We refer to this as the window period, and misunderstanding it can lead to catastrophic false negative diagnoses.
If a patient has a high-risk exposure on a Friday night and comes into the clinic on Monday morning demanding an HIV test, which test are we running and what are the limitations?
Well, you cannot run a standard antibody test on Monday morning. The immune system takes time to recognize the virus and generate detectable antibodies. The very first test that can identify an infection is a nucleic acid test, or NAT.
This test doesn't look for the body's response, right? It amplifies and detects the actual viral RNA circulating in the blood.
Yes. A NAT can become positive within 10 to 33 days post-exposure. But NATs are highly complex and expensive, so they aren't always the first-line screening tool.
The current gold standard for initial screening is the 4th-generation antigen antibody test. This test looks for both the patient's antibodies and a specific viral protein called the P24 antigen, which spikes very early in the infection before antibodies form.
And this test can accurately detect an infection within 18 to 45 days. The danger lies at the older, pure antibody tests, which include the rapid point-of-care test and the confirmatory Western blot.
Right, because these rely entirely on the presence of circulating IgG and IgM antibodies. It can take a patient's immune system anywhere from 3 to 12 Rits to produce enough antibodies to trigger a positive result.
That 12-week gap is the window period. A patient in the window period could have millions of copies of the virus in their blood, making them highly infectious to partners, while continually testing completely negative on a rapid antibody screen.
Wow. Once a patient is definitively diagnosed, how does the pathophysiology of the disease progress over time without pharmacological intervention? The notes divide the clinical course into 3 distinct stages.
Stage 1 is acute HIV infection. This occurs within the first 2 to 4 weeks following exposure. The virus is actively hijacking CD4 cells and replicating at an astonishing rate.
The viral load in the blood spikes to massive levels, making the patient incredibly infectious. Because the patient's immune system is still robust and actively fighting this massive viral surge, they typically experience severe acute retroviral syndrome, profound fatigue, fever, night sweats, swollen lymph nodes, and sometimes a maculopapular rash.
Crucially, during stage 1, the CD4 count remains relatively normal, usually greater than 500 cells per cubic millimeter, because the body is still replacing them as fast as they are destroyed.
Following that initial war, the immune system manages to bring the viral replication down to a steady, manageable level, establishing what is called a viral set point. This initiates stage 2 chronic asymptomatic infection, also known as clinical latency.
In stage 2, the virus retreats into the lymph nodes. It continues to replicate, but at much lower levels. The patient's CD4 count slowly begins to drift downward, usually sitting between 200 and 499.
The terrifying aspect of stage 2 is that the patient might feel absolutely fine, exhibiting 0 clinical symptoms for a decade or more. But beneath the surface, the virus is relentlessly grinding down the CD4 population, destroying the communication network cell by cell.
Which inevitably brings us to the diagnostic threshold of stage 3 AIDS. Acquired immunodeficiency syndrome. This is not just a worsening of symptoms. It represents the total collapse of the cellular immune response.
How is this strictly diagnosed for the exam?
A patient transitions from an HIV diagnosis to an AIDS diagnosis when one of 2 specific criteria are met. The first is strictly numerical. Their CD4 count drops below 200 cells per cubic millimeter. At that level, the immune system is effectively blind.
And the second criterion is clinical. The patient develops an AIDS-defining opportunistic infection, regardless of what their CD4 count is at that specific moment.
Exactly. Let's deeply examine those opportunistic infections, the OIs, because recognizing them is a massive nursing priority. These are pathogens, fungi, viruses, and parasites that exist everywhere in our environment.
A healthy person inhales them or ingests them daily, and their intact immune system swats them away effortlessly. But for an AIDS patient, these innocuous organisms become lethal invaders. What is the most prominent OI listed in the study guides?
The most common and often the defining initial presentation of AIDS is pneumocystis jirovecii pneumonia, or PCP. This is an airborne fungus that is ubiquitous in the environment.
In a patient with a CD4 count under 200, the fungus colonizes the alveoli of the lungs, causing massive inflammation and fluid exudate. The patient presents with profound shortness of breath at rest, a persistent high fever, hypoxemia, and a dry, non-productive cough.
Left untreated, it rapidly progresses to fatal respiratory failure. The pharmacological treatment is not a standard antifungal, but rather high doses of the sulfa antibiotic trimethoprim sulfamethoxazole, commonly known as Bactrim.
The pathology notes outline several other critical OIs that love to target specific organ systems. There's severe oropharyngeal candidiasis, a fungal infection that coats the entire mouth, tongue, and esophagus in thick, painful white plaques, making it incredibly difficult for the patient to swallow or eat.
There is cytomegalovirus, or CMV, a herpes family virus that aggressively targets the retina of the eye, causing hemorrhagic lesions that lead to irreversible blindness.
And there is toxoplasmosis, a parasitic infection often contracted from handling contaminated cat feces or eating undercooked meat. In an AIDS patient, Toxoplasma gondii crosses the blood-brain barrier and creates ring-enhancing necrotic lesions in the brain, presenting as severe headaches, altered mental status, and focal seizures.
We also see unique AIDS-defining malignancies, most notably Kaposi sarcoma. This is a cancer of the endothelial cells that line the blood vessels and lymphatic system, triggered by an opportunistic infection with human herpes virus 8.
It presents as distinctive, painless, purplish-brown lesions appearing all over the skin and frequently growing aggressively within the gastrointestinal tract and lungs. There is one specific opportunistic infection that requires a deep dive into nursing care priorities: cryptosporidiosis. This is an intestinal parasite that causes absolute havoc.
Yes, cryptosporidium attaches to the epithelial lining of the small intestine and disrupts the absorptive capacity of the villi while simultaneously triggering massive fluid secretion.
In a healthy host, it causes mild, self-limiting diarrhea for a few days. In an AIDS patient, it causes chronic, unrelenting, voluminous, watery diarrhea, sometimes exceeding 10 to 15 liters of fluid loss per day.
This leads to profound malabsorption, severe weight loss, and the devastating muscle atrophy known as AIDS wasting syndrome.
And the testable nursing priority here is critical. While administering antidiarrheals and maintaining strict infection control protocols are important, the absolute most urgent, life-saving priority for a patient with severe cryptosporidiosis is aggressive fluid and electrolyte replacement.
Yes, a patient losing 15 liters of stool a day will rapidly enter hypovolemic shock and suffer lethal cardiac arrhythmias from profound hypokalemia. You have to stabilize their hemodynamics before you can even attempt to treat the parasite.
Tracing the pathology of HIV gives us a clear picture of what happens when the immune defense grid completely fails to recognize outside invaders. The host is destroyed by opportunistic pathogens.
But that is only one side of the diagnostic muddy waters we started this deep dive with. The immune system failing to react is catastrophic. But what happens when the defense grid is fully powered? The CD4 generals are alert, the B cells are producing billions of antibodies, but the targeting software is fundamentally broken.
The patient suffers immense damage not from a virus, but because the immune system actively turns its weapons inward. Let's transition into Section 4, the body against itself, and deeply compare two devastating autoimmune connective tissue disorders: rheumatoid arthritis and systemic lupus erythematosus.
The contrast between these two diseases provides a masterclass in hypersensitivity mechanisms. Let's begin with rheumatoid arthritis, or RA. From a pathophysiological standpoint, RA is a highly targeted attack. We can appropriately label it the joint destroyer.
The primary battlefield for RA is the synovial membrane, the delicate tissue that lines the inside of freely movable joint capsules and secretes the lubricating synovial fluid. In RA, the immune system loses tolerance to the body's own proteins and begins producing autoantibodies, specifically rheumatoid factor and anticyclic citrullinated peptide, or anti-CCP.
Those autoantibodies bind together, creating the exact type 3 immune complexes we discussed earlier. These microscopic clumps of molecular garbage get trapped inside the synovial tissue of the joints.
The immune system detects them and triggers a massive inflammatory response. Macrophages and neutrophils swarm the joint space, releasing massive amounts of pro-inflammatory cytokines like tumor necrosis factor alpha and interleukin-6.
This chronic, relentless inflammation fundamentally alters the anatomy of the joint. The normally thin synovial membrane begins to hyperproliferate, thickening into a dense, aggressive mass of granulation tissue called a pannus.
This pannus isn't just swollen tissue. It is highly vascularized and packed with destructive enzymes. It literally grows over the articular cartilage, releasing matrix metalloproteinases that dissolve the cartilage and activating osteoclasts that bore directly into the underlying bone. It destroys the joint architecture from the inside out.
Because of this specific localized destruction, the clinical presentation of RA is distinct and highly testable. The joint involvement is characteristically bilateral and symmetric. If the immune complexes are depositing in the right wrist, they are also depositing in the left wrist.
It typically manifests first in the small joints of the upper extremities, the proximal interphalangeal joints of the fingers, the metacarpophalangeal joints of the hands, and the wrists.
And the hallmark symptom that every nursing student must recognize is the nature of the joint stiffness. It isn't just the mechanical creakiness of osteoarthritis that gets worse after a long day of walking.
The hallmark of RA is profound morning stiffness that lasts for more than 1 hour after waking. The patient wakes up and their hands are locked, swollen, and agonizingly painful.
As the untreated disease progresses into the late stages, the destruction of the ligaments and bone leads to severe, irreversible structural deformities. We see ulnar deviation, where the fingers visibly angle outward toward the pinky side of the hand, and swan neck deformities, where the finger joints hyperextend and flex in a rigid zigzag pattern.
Diagnostically, we look for the presence of those autoantibodies. An elevated rheumatoid factor, or RF, is common, but as the notes emphasize, an elevated anti-CCP antibody titer is vastly more specific to RA and can often be detected years before clinical symptoms appear.
A nurse will also note significantly elevated erythrocyte sedimentation rate, the ESR and C-reactive protein, or CRP levels, which are nonspecific markers that confirm massive systemic inflammation is actively occurring.
Now, the nursing care and patient education for an RA patient involves a highly counterintuitive yet critical concept. I saw this emphasized repeatedly in the clinical reasoning notes. Imagine a patient experiencing a severe acute RA flare. Their joints are red, visibly swollen, and incredibly painful.
The logical instinct is to put them in bed, immobilize the joints, and let them rest until the flare subsides. But the notes say that is exactly the wrong approach.
Prolonged immobility is a biological trap for an RA patient. While they certainly need to pace themselves and balance rest with activity to manage profound fatigue, complete immobilization allows the inflammatory exudate and the destructive enzymes to pool and stagnate within the joint capsule.
It drastically accelerates the stiffness and the permanent loss of range of motion. They must keep those joints moving with gentle, active range of motion exercises, even during a painful flare.
The physical therapy modalities are also specific to the timing of the symptoms. To manage that agonizing morning stiffness, the nurse should educate the patient to use heat therapy, taking a hot shower immediately upon waking, or using heated paraffin wax dips for their hands to increase blood flow and relax the tissues.
Conversely, for the acute edema and throbbing inflammation that occurs during an active flare-up later in the day, cold therapy or ice packs are indicated to cause localized vasoconstriction and numb the pain pathways.
So, rheumatoid arthritis is a highly targeted, localized attack, primarily destroying the synovial joints. Now, let's contrast that with systemic lupus erythematosus, or SLE. If RA is the joint destroyer, SLE is historically known as the great imitator. Why is it called the great imitator? Is the pathophysiology that fundamentally different?
Well, it is driven by the same type 3 hypersensitivity mechanism immune complexes depositing in tissues, but the target is vastly broader. In SLE, the body develops autoantibodies against its own nuclear material.
These are called anti-nuclear antibodies, or ANAs, and specifically anti-double-stranded DNA antibodies. Because every single cell in the body contains a nucleus and DNA, these immune complexes can form and deposit literally anywhere there is connective tissue or microvasculature.
It doesn't just target the joints. The complexes lodge in the skin, the delicate blood vessels of the brain, the pleural lining of the lungs, the pericardium of the heart, and crucially, the filtration system of the kidneys. Because it damages so many disparate organ systems simultaneously, SLE can mimic the symptoms of dozens of other diseases.
The study guides focus heavily on the specific environmental and physiological triggers that can initiate or exacerbate an acute lupus flare. They categorize them as the NCLEX, 4S's sun, stress, sickness, and hormones, specifically the shifting hormones of pregnancy. Let's explore the biological mechanisms behind these triggers. Why does sunlight cause an internal autoimmune disease to flare up?
The mechanism involving ultraviolet radiation is fascinating. When a lupus patient's skin is exposed to UV light, the radiation directly damages the DNA of the keratinocytes, the skin cells. This damage triggers apoptosis, and the dying skin cells spill their fragmented nuclear material into the surrounding tissue.
In a healthy person, macrophages quietly clean this up. In a lupus patient, the immune system immediately detects the spilled DNA, recognizes it as a massive foreign antigen attack, rapidly generates anti-DNA autoantibodies, and triggers a violent systemic inflammatory cascade.
The other triggers follow a similar logic of broadly ramping up the immune system. Extreme psychological stress or a secondary sickness, like a viral infection, naturally increases the baseline activity of the immune system, inadvertently giving the autoantibodies more resources to attack the body.
And the massive hormonal shifts of pregnancy, particularly the rising levels of estrogen, have a direct stimulating effect on the humoral immune response, which often dramatically exacerbates SLE symptoms.
However, there's a very important distinction highlighted in the prep questions regarding physical activity. A student might logically deduce if physical stress triggers a lupus flare, then a patient should avoid exercise.
The sources explicitly state that moderate low-impact exercise does not exacerbate SLE. In fact, it is highly recommended because it helps combat the profound chronic fatigue associated with the disease and helps maintain joint mobility and cardiovascular health.
Clinically, how does a patient with active SLE present? The multi-system nature of the disease creates a complex picture. The absolute classic textbook dermatological sign is the malar rash, commonly referred to as the butterfly rash.
It is a dry, raised erythematous maculopapular rash that spreads symmetrically across the bridge of the nose and the cheeks, entirely sparing the nasolabial folds. Patients also experience extreme photosensitivity, developing severe rashes on any sun-exposed skin.
They often present with polyarthralgia pain in multiple joints, profound debilitating fatigue, and frequently unexplained fevers.
But here is the ultimate clinical priority for a nurse assessing a lupus patient. The joint pain, the profound fatigue, and the butterfly rash are expected hallmark findings. They cause immense suffering, but they are not immediately life-threatening. The absolute most dangerous, lethal complication of systemic lupus erythematosus is lupus nephritis.
This cannot be overstated. The kidneys contain millions of microscopic filtration units called glomeruli, which are basically tiny knots of highly permeable capillaries. When those circulating immune complexes pass through the kidneys, they become heavily trapped in the glomerular basement membrane.
The resulting inflammatory response utterly destroys the kidney's ability to filter the blood, causing massive amounts of protein and red blood cells to spill into the urine while retaining toxic waste products in the blood.
If a nurse is assessing a lupus patient, whose primary complaint is joint pain, but during the assessment, the nurse notes new-onset peripheral edema, swelling in the lower legs or puffiness around the eyes, a sudden spike in blood pressure indicating fluid overload, or lab results showing a rising BUN and creatinine, or a significant drop in hourly urine output, that is an immediate red alert clinical emergency.
It indicates rapidly progressing kidney failure. As the memory trick for the exam goes, skin and joints hurt, but kidneys kill.
Patient education for SLE is largely focused on trigger avoidance and skin protection. Because of the severe photosensitivity and the risk of UV-induced flares, patients must relentlessly avoid direct sunlight, wear protective, wide-brimmed clothing, and apply SPF 30 or higher sunscreen daily.
The notes also specify using mild, protein-based shampoos because SLE frequently causes significant alopecia or hair loss. Furthermore, patients are instructed to avoid applying harsh drying powders or alcohol-based astringents to their skin rashes. They require gentle, non-perfumed, moisturizing lotions to maintain skin integrity.
The destruction caused by RA and SLE is immense, but it is fundamentally driven by the autoimmune inflammatory cascade, the body's own white blood cells causing friendly fire. As we transition into the final segment of our deep dive, we need to examine two other disorders that cause excruciating musculoskeletal pain, but through entirely different mechanisms.
They mimic the joint pain of autoimmunity, but without the autoantibodies. Let's explore the pathophysiology of gout and fibromyalgia in Section 5.
Gout is a brilliant example of a purely metabolic error, masquerading as an inflammatory joint disease. It is formally classified as a crystal-induced arthropathy.
The pathophysiology of gout entirely centers around a disruption in purine metabolism. Purines are natural chemical compounds found within the DNA and RNA of all living cells, and they are highly concentrated in certain foods.
When the human body breaks down these purines, the end byproduct is a chemical called uric acid. Normally, the kidneys filter uric acid out of the blood and excrete it in the urine.
But in a patient with gout, this pathway breaks down. The liver either overproduces uric acid due to an enzyme defect, or the kidneys fail to excrete enough of it. This leads to hyperuricemia, chronically high levels of uric acid circulating in the bloodstream.
Uric acid is relatively harmless when dissolved in the blood. The agony begins when the concentration gets too high, or the temperature of the blood drops slightly, causing the uric acid to precipitate out of the solution and crystallize.
It forms these microscopic, incredibly sharp, needle-like structures called monosodium urate crystals. These jagged crystals selectively deposit directly into the synovial spaces of the joints, most commonly targeting the metatarsophalangeal joint of the great toe, a condition known as podagra.
Once those needle-like crystals embed in the joint, the body's innate immune system, specifically the neutrophils, detects the tissue damage and swarms the area, attempting to phagocytize the sharp crystals.
The resulting acute inflammatory response causes the joint to become violently red, swollen, hot to the touch, and so agonizingly painful that even the weight of a bedsheet resting on the toe is intolerable.
The risk factors for developing hyperuricemia are well-defined high body mass index, excessive alcohol consumption, which directly decreases renal uric acid excretion, the use of thiazide diuretics, and a diet excessively high in purine-rich foods.
For the exam, you must be able to identify these high purine foods, organ meats like liver and kidneys, rich shellfish, and specific oily fish like sardines and anchovies. I came across a highly specific physiological trap in the study guide regarding patient education for weight management in gout.
Oh, about fasting.
Yes, the guide explicitly states that while gradual weight loss is beneficial, gout patients must absolutely avoid fasting, starvation diets, or rapid weight loss regimens like strict ketogenic diets. Why would eating less cause a massive gout attack?
It is a fascinating biochemical bottleneck in the kidneys. When a patient completely fasts or adopts a strict starvation diet, their body rapidly depletes its glycogen stores and begins burning fat for energy.
The byproduct of rapid fat metabolism is the production of acidic molecules called ketones. The biological trap is that the proximal convoluted tubules of the kidneys use the exact same transport mechanism to excrete ketones as they do to excrete uric acid.
They share a single exit door. And the kidneys preferentially prioritize excreting the highly acidic ketones to prevent ketoacidosis. As a result, the uric acid is blocked from leaving, it builds up massively in the bloodstream over just a few days, crystallizes, and triggers an agonizing acute gout flare.
That perfectly connects the dietary choices directly to the cellular mechanism. Now, managing gout pharmacologically requires two entirely different strategies treating the acute fire and preventing future fires.
During an acute attack, the goal is purely anti-inflammatory. You administer strong NSAIDs like indomethacin and a highly specific gout medication called colchicine.
Colchicine doesn't lower uric acid. It disrupts the cellular microtubules inside the neutrophils, essentially paralyzing them so they cannot migrate to the joint and cause inflammation.
Conversely, for chronic maintenance therapy to prevent future attacks, you must address the underlying metabolic error. We utilize medications like allopurinol, which is a xanthine oxidase inhibitor. It actively blocks the enzyme in the liver responsible for producing uric acid.
Or we use probenecid, a uricosuric agent, which alters the renal tubules to force the kidneys to excrete higher volumes of uric acid into the urine. Finally, we arrive at fibromyalgia. This condition is conceptually fascinating because it represents a complete paradigm shift from everything else we have discussed.
It causes widespread, debilitating chronic pain, but when you look at the labs or the x-rays, there is zero visible inflammation. There are no swollen joints, no destructive pannus formations eroding the bone, no autoantibodies, and no uric acid crystals.
Fibromyalgia challenges our traditional understanding of pain. It is not an autoimmune disease, and it is not an inflammatory disease. The pathophysiology lies entirely within the central nervous system. It is a disorder of central sensitization. The brain and the spinal cord physically change how they process nociceptive pain signals.
The research indicates that patients with fibromyalgia have significantly elevated levels of substance P and glutamate, the neurotransmitters that amplify pain signals in their cerebrospinal fluid.
Simultaneously, they have depleted levels of serotonin and norepinephrine, the neurotransmitters responsible for dampening and inhibiting pain pathways. The volume knob on their central nervous system is essentially stuck at maximum, while the mute button is broken.
This results in two distinct clinical phenomena: hyperalgesia, where a mildly painful stimulus is perceived as excruciatingly agonizing, and allodynia, where a completely non-painful stimulus like a gentle touch, the brushing of clothing, or light massage is processed by the brain as severe burning pain.
The physical assessment often involves identifying pain elicited by palpating specific symmetrical trigger points across the neck, shoulders, chest, and hips. The pain is invariably accompanied by severe, non-restorative sleep disturbances.
The patients physically cannot reach the deep delta wave stages of sleep, leaving them in a state of chronic profound exhaustion, often described as fibro fog. They also experience a heightened sensitivity to noxious environmental stimuli, such as bright lights, loud noises, and strong odors.
Because the pathophysiology is rooted in neurotransmitter dysfunction rather than immune complex deposition or inflammation, the pharmacological approach is entirely different. We do not use immunosuppressants or high-dose NSAIDs.
The treatment strictly targets the nerve pain and the sleep architecture. We utilize serotonin norepinephrine reuptake inhibitors, or SNRIs, like duloxetine, to increase the presence of those pain-dampening neurotransmitters in the synaptic cleft.
We use anticonvulsants, specifically pregabalin, which binds to calcium channels in the central nervous system to calm hyperactive nerve firing. And we frequently prescribe tricyclic antidepressants like amitriptyline, administered at bedtime to manage the severe sleep disturbances and block ascending pain pathways.
That brings us to the culmination of this massive cognitive journey. We have mapped out an immense amount of complex microscopic terrain today.
We truly have. We built this foundation from the ground up, starting with the body's elegant natural lines of defense, the acidic barriers of the skin, the aggressive chemotaxis of the innate neutrophils, and the brilliant memory-driven cellular and humoral networks of the B cells and T cells.
We explored how we artificially modulate that exact system, safely building memory with live and attenuated vaccines, or forcefully shutting the cellular communication network down with high-alert medications like prednisone, cyclosporine, and methotrexate to prevent the destruction of transplanted organs and inflamed joints.
We analyzed the devastating pathophysiology of what happens when the ultimate immunosuppressive agent, the HIV retrovirus, infiltrates the body, methodically hijacking and assassinating the CD4 generals, leaving the biological door wide open for ubiquitous environmental fungi and parasites to cause lethal opportunistic infections like PCP pneumonia and cryptosporidiosis.
We witnessed the tragic friendly fire of autoimmunity, contrasting the localized, panis-driven joint destruction of rheumatoid arthritis with the widespread systemic immune complex deposition of systemic lupus erythematosus, always keeping our clinical focus on the deadly threat of lupus nephritis.
And finally, we differentiated the inflammatory pain of autoimmunity from the metabolic crystal-induced agony of gout and the neurotransmitter-driven central sensitization of fibromyalgia.
For you listening, the nursing student preparing to sit for this high-stakes exam, the fundamental takeaway from this deep dive is this mastering the immune system is entirely about recognizing the underlying pathophysiological patterns. Do not simply attempt to memorize isolated flashcard facts or disjointed lists of side effects.
If you understand the biological why ketones compete with uric acid in the kidneys, why the Varicella vaccine is lethal to an immunocompromised patient, why HIV pharmacology requires attacking multiple stages of reverse transcription, and why the specific cellular targets in lupus threaten the renal filtration system, you will not just pass the exam. You will possess the deep clinical reasoning required to anticipate devastating physiological complications long before they become fatal.
You absolutely have the capability to master this material.
And as we conclude, I want to leave you with one final provocative thought to ponder as you continue your studies. We spend an enormous amount of time and resources in modern medicine, and we spent this entire deep dive discussing it, trying to forcefully manipulate the system. We are constantly trying to either boost the immune system up with artificial antigens or violently suppress it down with highly toxic drugs that cause horrific side effects. But consider the trajectory of current biotechnology. What if the future of nursing and pharmacology isn't about fighting the immune system, but completely reprogramming its source code?
That is the most fascinating frontier in modern immunology.
Think about the mechanics of the mRNA vaccines that emerged so powerfully in recent years. They bypass the traditional antigen presentation entirely. They literally hand the host's ribosomes a temporary line of genetic code to manufacture a specific target. What if, perhaps sooner than we think, that exact same messenger RNA technology could be utilized not to fight a foreign virus, but to teach a confused autoimmune body, a body relentlessly ravaging its own kidneys in lupus or destroying its own joints in rheumatoid arthritis, to finally recognize itself again? What if we could deliver a targeted biological patch that simply turns off the friendly fire at the cellular source, rendering drugs like methotrexate and prednisone obsolete? The diagnostic X-ray machine might be permanently broken when it comes to observing the immune system, but the underlying cellular code is finally being cracked. Good luck on the exam, trust your knowledge, and we'll see you on the next deep dive.